Today, one of the things I'll be talking about is management of hypertension in high-risk population. Honorable chairpersons and ladies and gentlemen. Now, we know that hypertension is a real problem. It's the single largest contributor to cardiovascular disease. And what do you mean by that, the high-risk population? Well, hypertension, when associated with some of the comorbid conditions or complications of certain physiological conditions, we call it hypertension in special situation. Comorbid conditions like COPD or diabetes, complications like ischemic heart disease, stroke or CKD, and physiological conditions like very young, very old, and the pregnancy. Well, high-risk population needs, some of them, like COPD, it's not a high risk, but you have to pay some attention to what type of drug you are using. And some are high risk because in the elderly and the young, you have to be very cautious in what type of drug you are using in CKD or peripheral vascular disease, like that. And that's a long list like this. So I will not be talking about all of this. Particularly, I'm not talking about hypertension with pregnancy because that's a real big chapter and we should pay more attention to it. Remember that in this country, 24% of all death, pregnancy-related death, are related to pregnancy-induced hypertension. We don't pay that much attention to it, but we should know it. Now, the general management algorithm we know, we start with ACE inhibitor, ARP or calcium channel blocker, add on diuretic, and then add on others. But when in a special situation, that algorithm is not really important. For example, look at the hypertension patient with coronary artery disease. The inter-heart study, which involved the 52 countries, including Bangladesh, showed that 20% of the MI are attributable to hypertension. Now, one meta-analysis reported if you reduce the blood pressure by 10 millimeter, the systolic BP, the risk reduced of MI is 17%. So it's very imperative that we should reduce the blood pressure. And the target is usually, as we say, 130/80. And in the coronary artery disease, RAS blockers, beta blocker, and calcium channel blocker are in equal footing. Otherwise, beta blocker in the general algorithm is the fourth child of a family, like that. But here, it's in the first group. ACE inhibitors become indispensable as well as ARNI when the patient has heart failure. Now, the RAS blockers particularly protect the endothelium through anti-inflammatory, anti-apoptotic, and the effect, as well as they have the great effect on LV remodeling. And after MI, the studies have shown beta blockers except atenolol reduce the risk of recurrent coronary artery disease by 31%. Very interesting is that recent data are saying when you are using very potent statin and dual antiplatelets, etc., that effect of beta blocker is not that of magnitude. It's not that important. Still, it is good and important. So we should be using beta blocker or long-acting calcium channel blocker for symptom relief, particularly in patients with ischemic heart disease. And the target is 130/80. That should be our target. And as we say, here, look at the box. In the box, they are saying GDMT beta blocker. What do you mean by GDMT beta blocker? That means they are saying blood pressure control or relief of angina include the beta blockers, carvedilol, metoprolol tartrate or succinate, nadolol, bisoprolol, propranolol, and timolol. Avoid beta blocker with intrinsic symptomatic activity. Virtually, they are not available. But atenolol should be used because it is less effective than placebo in reducing cardiovascular event. So the great atenolol has fallen down. Now, what about chronic heart failure? Hypertension is perhaps the most important factor, and Framingham Heart Study 20-year follow-up has shown hypertension precedes the incident heart failure in 91% cases. And compared with the normotensive, the hazards of heart failure are twofold higher in men and threefold higher in women. So we should have to reduce it, and both in heart failure preserve ejection fraction or reduce ejection fraction. In both cases, the reduction of pressure, maintaining it at a normal level is very important. And the steps are, as we have seen, ACE inhibitor, ARP, CCB or diuretic, and then add on beta blocker at any stage when the patient have heart failure. And the target is we should also use SGLT2 inhibitors, and ARNI can be substituted instead of RAS inhibitor, ARP. Now, what about preserved ejection fraction? we often forget the role of diet. The DASH diet is associated with favorable changes in ventricular diastolic function, arterial elastase, and the lowering of blood pressure improves the diastolic function irrespective of the type of antihypertensive treatment used. But, there is a but. MRA, RAS blocker, diuretics, they control hypertension very well, but they could not consistently improve the morbidity and mortality in heart failure with preserved ejection fraction. And what about RAS, heart failure with reduced ejection fraction? Here, there are clear-cut evidence the RAS blockers, MRA beta blocker are very good, and particularly ARNI. And SGLT inhibitor should be used, diuretics as needed, and if we have to use any calcium channel blocker, we can use amlodipine or felodipine. And to prevent it, we have to use any sort of heart failure treatment. We should, in case of a hypertensive patient, any antihypertensive is good enough to reduce the incidence of heart failure. But beta blockers reduce blood pressure, but when the patient has heart failure, it has protective effect. When the patient do not have yet heart failure, beta blocker do not have that much of significant effect. Here, ACE inhibitor, ARB are the supreme. Calcium channel blocker, beta blocker are the lesser key. What about CKD? Hypertension causes CKD and may be the result of CKD. And here, the mask and resistant hypertension is very important. Also, the blood pressure variability and nocturnal hypertension. So, long-acting drugs are important. And here the target is 130/80. What do we mean by long-acting drugs? Amlodipine is one. Remember that nebivolol has 24-hour half-life. Bisoprolol, longer half-life. Olmesartan, telmisartan, longer half-life. These are the drugs, including diuretic, that we should be using. But volume overload in dialysis patient is an important thing, and we should be paying attention to that. Chlorthalidone in one study have showed efficacy in stage 4 CKD, and where, along with loop diuretics, it can reduce the blood pressure quite well. After transplantation, calcium channel blockers are perhaps better. The target is less than 130/80. In aortic dissection, the most important thing is you have to reduce the blood pressure, and you have to reduce it quite well. Studies have shown blood pressure is well controlled, but if it is 110/70, it's far better than when it is 130/80. So in case of aortic aneurysm or dilated aortic root in bicuspid aortic valve, or any patient with aortic disease, you have to reduce and keep the blood pressure as low as possible, and you have to use beta blockers in all sorts of aortic disease. What about valvular heart disease? In aortic stenosis, beta blocker preferable, but whatever antihypertensive you use in AS, you have to use it at lower dose and titrate gradually upwards. In aortic insufficiency, again, the other way around, you should avoid beta blocker or any other drug that reduces the heart rate. What about hypertension encephalopathy? We have to use IV parenteral drug, and the basic principle is you reduce the blood pressure by no more than 25% within the initial hour, followed by gradual blood pressure reduction to 160/100. And that should be targeted by 4 to 6 hours or 8 hours. And after that, over the next 24 to 48 hours, gradually reduce the pressure. So, an oral antihypertensive should be started later on. Acute cerebral hemorrhage, the target should be that the pressure should not be lower than 140/90. Remember that. Class 3. That's the point they are emphasizing. Ischemic stroke, as we have said. For secondary prevention of stroke, thiazide diuretic, ACE inhibitor, or ARB, or a combination is far better than any other drugs. Perioperative hypertension management, we have to do the test. Most important is you have to keep the ACE inhibitor or ARB should be hold 24 hours preoperatively and restart after that. And thiazide diuretic calcium channel blocker should be continued. Beta blocker, if continued, should continue, but you should not start anew. Endocrine hypertension is another thing. For hyperthyroidism, propranolol in high dose is the best drug that should be used. There's a choice. They are saying hyperthyroidism and hyperthyroidism. I have to rush. The time is short. In pheochromocytoma, the drug which has the good effect is not available in our country, phenoxybenjamin. What can we use? CCB, diltiazem. That can be used. Can we use beta blocker? Yes, but along with an alpha blocker, a powerful alpha blocker, that we should be using. Ladies and gentlemen, it's a big chapter, so we have to hurry. But we have to know the basic principle. Whatever you do, all the special situations are not similar. So the high-risk population depends upon, the treatment depends on the degree of hypertension, the related comorbid condition, and the complications. The treatment urgency, aggressiveness, or choice of antihypertensive drugs will vary in different situations. So a multifaceted and multifactorial approach with long-term sustainable goal should be the norm in these patients. Ladies and gentlemen, thank you.
Thank you, sir, for your